Okay, so let's finish the shoulder session with the arthroplasty topic. We see in our outpatient clinic these kind of patients. So what you see here, the CT scan, MRI scan, normal X-ray. Here this is a normal X-ray with a head, with no head. So now it's for me important to have a good classification. Why do you think? Do you have an idea why? What do you want to? What do we want to classify now? What do we want to find out now? Do you have? Yeah, sorry. Yeah, why is that so important? Yeah, when you're doing what? Yeah, total shoulder. But we have two possibilities of shoulder arthroplasty, or reverse or anatomic. So that's for me again the important thing to judge at the beginning what kind of procedure will be necessary for this patient if necessary. So my workflow is that I have again a very good patient history, clinical examination with range of motion to judge if the rotator cuff is intact or not, a radiological examination with a precise diagnosis, and then we can say what kind of procedure we are doing. There's a very nice paper that is called Glenohumeral Osteoarthritis, What the Surgeon Needs from the Radiologist. This is very good to read, because here you can see or you can find what kind of X-rays you need, what kind of CT scan you need, what MRI you need, and what kind of angles you measure, and so on. For me, it's quite important that we have all these X-rays here in our clinics, AP, Greshey sign, and so on, where we can judge. Also, like here, the axillary view. You can see here on the axillary view. What do you see here? Yeah, we have a very great subluxation, and okay, thank you. And so these are X-rays that are very important to judge what kind of prosthesis I'm looking for. So where I'm going to end up. So classification is Kellgren, Lawrence, Simonson, and Hamada. Hamada tells us about the acromial-humeral distance. So it judges or it evaluates the rotator cuff. Then Simonson-Pretot tells us something about the osteophytes here in the recessus, so where you can see here like this. So those people have a lot of reduced range of motion. And Kellgren Lawrence gives us an information how much cartilage is intact or if there is all cartilage gone. Yeah. So this is very important for me, these examinations to judge what is, because then we have a three-dimensional examination with an MRI or a CT. For the Schill-Walsh classification, we have the Walsh. We take the CT scan or the axial view of the X-rays, but this is quite hard to interpret. So I would take the CT scan, and there you judge. This is a centered shoulder, and now it is going to be more uncentered, or a dysplastic glenoid. This is very important to know, because for what decision? What do you think? When you're thinking about how to fix I mean, it does not matter if you do a reverse or an anatomic, but you cannot go for an anatomic in this shoulder, for example, because you would have too much wear, subluxation problems, and so on. So you have to judge first, and it would be, you will go to court for this reason when you're putting a pack here in this kind of, or when you're going for anatomic in this kind of dysplastic glenoid. So this is quite important that you know which glenoid you have on an axial view, and You have also the Favart classification. It's not written here, but a Favart classification tells you how much superior erosion you have on the glenoid. Yeah? So when you have a decentered shoulder, for example, when you have a calf tear arthropathy, you will have more erosion on the top. And, what is very important is that you have a lot of, when you implant the glenoid, you are going to risk that you implant the glenoid in a superior inclination, what's not good for the longevity of the shoulder prosthesis. Huh? So these are the classifications. So if you have a look at these patients, what you see here, you see a typical omotrosis, but what's the most important thing on the coronal view for you now? Yeah, for me it's very important to judge, okay, there is no rotator cuff. Yeah, I have a superior subluxation, no rotator cuff. Look at the fatty degeneration here of the supraspinatus and also the infraspinatus here. Then when you look at the axial view, there is the glenoid, I think there is no nice glenoid. And here you see, you can judge the cartilage. So these are all very important informations for your procedure. So what are you heading for in this case? What do we have here? This is a very young patient. Yeah, he's suffering. I think he had chemotherapy and he has humeral head necrosis, so he's suffering from that pain. So, but on the axial view, on the sagittal view, I see that the rotator cuff is intact, the muscles are intact. Here on the coronal view, it's so I would recommend here, and there we don't have that much subluxation in the back. Maybe we can head for a anatomic endoprosthesis. And in this case, we have a complete we have a subluxation of the head, but I mean the supraspinatus seems to be intact. Here it is not so bad, it looks fine. We have a halo here of fatty degeneration, but we have a big dorsal subluxation of the head and erosion of the glenoid. So you can say, okay, this is a Schillwalsh B2 or D, something like this. So to make a stable anatomic shoulder is nearly impossible. So shoulder arthroplasty, everybody knows, 1950 invented by Neer just for the treatment of fractures. It was then a new concept, 1980s, by Paul Cromont, the reverse, where you are just using the delta muscle to compensate the rotator cuff. And now I'm just focusing on these two ideas, ideas. As you know, anatomic shoulder arthroplasties. When you look at the registers, this is from the Australian registers, the total stemmed anatomic, they are going back. So the most people are implanting reverse arthroplasties. From my point of view, this is quite interesting to implant. It is quite interesting to have these cases and not to start with a reverse. The reverse is more predictable. Bless you, it's more predictable. But I will also always go for an anatomic if possible. Because you always you can also have problems, of course, with the anatomic, but also with the in reverse. So contraindication for a total shoulder arthroplasty is the insufficient glenoid bone stock, the rotator cuff arthropathy, deltoid dysfunction, irreparable rotator cuff, and in any case, it does not matter if reverse or anatomic, the acute infection. So what are the revision cases, revision causes? The revision causes for the anatomic shoulder prosthesis is the calf tear arthropathy. So it rises, the more years you have it, the more risk you have that you will suffer a calf tear arthropathy. That's due to the fact that there is metal inside and that it's not that stable like you thing. But the second one is instability. Does anybody know why instability? What can be the reason for instability? Yeah, but when you implant the shoulder prosthesis, what can be a reason for an instability? Huh? Yeah, rotator cuff, subscap. So what we're thinking, you have the anterior escape when the subscap is not fixed well. So when you are, here is a review of 3,860 shoulders, and they found out the weak point in a shoulder prosthesis is the glenoid. In the anatomic shoulder prosthesis is the glenoid. So the glenoid is the limiting factors, and there are a lot of different concepts how to fight against this. So first of all, there's the deltopectoral approach that is mandatory for the implant of the shoulder prosthesis, and the rotator cuff. A lot of people are discussing how to peel off or how to do an osteotomy for the subscap or a refixation of the subscap. We do a osteotomy of the subscapularis, and we refix it after the surgery or at the end of the surgery with some sacklage to the bone again. And for me, it is easier to do that because you can also close the rotator interval. And when you close the rotator interval or the pulley up there, you have a good fixation to the supraspinatus, and the infraspinatus will heal in a bony fashion. And so that's why I think it's better than the peel off or the osteotomy, the tenotomy. So technical considerations, what can we do here in these cases where we have a worn glenoid? Nowadays, I mean, we don't use that because it is also very dependent on the company you use. We don't use these pegs. The peg, as we heard, they have the peg is the weak point in the rotator cuff. So when we have too much backside wear, or the glenoid there is too much erosion of the glenoid in the back, you are not able to implant the glenoid that it will be stable. So you have to augment it on the back side. This can be done by these polyethylenes. They don't have that bad results, but if you have this backside wear, you have to think about such a possibility to do that. So the glenoid, we have different kind of glenoids. The glenoid here is a keeled, and that's a pegged one. The keeled one don't have that good results. We have a better, we have less erosion, less loosening with the pegged ones. So these are uncemented glenoids, and they are just fixed here with the central peg, and those little pegs, they can be cemented. Yes. So glenoid loosening, what can be learned? That's around a group around Madsen. What can be learned from 250 glenoid components that failed? Here again, they found that 72% had a loosening, 69% had a glenoid wear, so they had some osteolysis in the bone. That's not good. And 51 were decentered head, so they had this rocking horse loosening. But that can be the reason. Why do you have a rocking horse phenomenon? Do you know? Does anybody know that? If you have too much resection on the head, you make the joint too loose, so the rotator cuff does not have enough tension, and when the rotator cuff does not have too much tension, there is too much AP translation, and so you have this rocking horse phenomenon. So their recommendation was that intact rotator cuff, correct placement of the glenoid, and adequate tensioning of the cuff is essential to reduce the risk for glenoid loosening. So what can you do in the B2 glenoid? This is the B2 glenoid. This is where we have this subluxation, and you see this is the new glenoid here. It develops when it is luxating back. What can you do? They tried to, so they did 239 shoulder prostheses. One group was they reamed asymmetric. In one group they performed the bone grafting, and in the other they used wedges. In all of those cases they had 42% loosening, and they found out that the most the biggest group was 15%, where they did this asymmetric reaming. Why do you think asymmetric reaming, or what caused the asymmetric reaming? When I do an asymmetric reaming, first of all, I try to correct the version of the glenoid. But when I do that, because of too much subluxation posterior, I have a lot of medialization of the glenoid and the head, so I don't get too much tension on the cuff, and then I have this rocking horse. That's why they have that's the biggest group of loosening. Bone grafting, they had a loosening of 9-10%, and when they did some augments, or when they used some augments, they had 0% of loosening. So this is very company driven, and it is dependent on the company if they provide you this kind of glenoids. So you see they all have some wedges on the back, so you have to calculate at the beginning how much for how much you want to correct the shoulder, and then you implant these kind of wedges where you have a good correction for the implant, and this is another possibility to stay on an anatomic side of shoulder prosthesis. In other cases, you have seen asymmetric reaming doesn't work. Bone grafting works in 90%, but the best would be wedges or these kind of glenoids. Also here we have porous metal wedges where you can, where you always have to, you need a company that provides you also with a special glenoid, because this is poly, the glenoid is poly, these are tantalum or metal, and they have good results in with a follow-up of 84 months for the wedged group. You always you also have to think about the loosening and the problem on the stem side. Yeah? So you have to discuss. Always think also not the glenoid is important, also the humerus is important. You have to implant it in a proper position, not in a valgus, not too much varus. It should be straight down there. So that would be good. Then you have to take care that you don't have an overstuffing here, because when you have an overstuffing, what will happen? You will cause the biggest reason for revision. And what's that? The secondary cuff arthropathy. So when you are too big here, you will have too much strength on the rotator cuff, and that will cause these problems. So anatomic preoperative planning, yes, a true AP to know how much wear we have in the backside. Axillary view is mandatory. CT scan nowadays, we always use a CT scan because we get a three-dimensional reconstruction, and we also know how much retroversion the humeral head will have. This is very important. And the MRI to evaluate the muscles. Yeah, so this should be no advertisement, but it is we are using this system. But we get these information, and for me this is really great, because I know I send them to the CT scan. They make a CT. They have a protocol where they have a CT scan of the elbow, the shoulder, and the scapula, and then they give me a precise information how much retroversion of the humeral head I have, how much retroversion of the scapula I have, and this is the most important information for me for implanting the two components in a proper way during the surgery. So now when total shoulder, anatomic total shoulder does not work, we are going for a reverse shoulder arthroplasty. This is the indication, I think, is clear. We have a cuff tear arthropathy, pseudoparalysis due to anterior superior escape, proximal humeral fracture in the elderly patients, rotator cuff insufficiency equivalence, and failed arthroplasty or anatomic arthroplasty. The contraindications is the delta deficiency, acromion deficiency, glenoid osteonecrosis, and osteoporosis, and the active infection, of course. Yeah. Also here, we have the causes for revision is the instability. It's the highest percentage here, the instability. Especially in this, like in these cases, we will discuss it a little bit later. I have a special case for you. Instability is one of the most reasons for revision, for doing the revision in the shoulder arthroplasty. So when we're doing the shoulder arthroplasty, in this case, because we will see later, you will see the difference. In this case, this was a very stable case, stable shoulder when we finished the surgery, and when he came, we saw. I did not saw a reason why that should why for the luxation, but afterwards and you see there is the configuration here looks very same. So I just used a little 3 millimeter higher polyethylene to make it stable again, and this was not an iatrogenic luxation due to an iatrogenic failure of the implantation. No, this man was walking with his dog, and the dog pulled on the arm, and then it luxated. So instability, when does instability appear? Insufficient tensioning of the delta muscle, but that looked fine. Superior tilt of the pace plate. You remember I told you that the Favart classification gives you an explanation how the glenoid is tilted, and that's also interesting when you're doing these. I mean, we will see later, but when you're doing these, when you get this protocol, you also know the inclination of the retroversion inclination here, 0 degree of inclination here, but in most cases we see 6 degrees of inclination, superior inclination, and so on. So this gives me a good and precise information how the glenoid is fixed. So next. And that's very important for me because I don't want to implant this glenoid in a superior inclination. So when I know this is 6 degrees of superior inclination, I ream a little bit more on the lower part of the glenoid so that I have a proper inclination of my base plate and my glenosphere. Yeah? Of course, we have axillary nerve injuries or acromion fractures. They are a reason for the acromion, for the luxation, and the small size of glenospheres is also a risk factor for instability in the reverse shoulder arthroplasty. So, bigger glenosphere improves stability, improves range of motion, and lateralizes and also the lateralizing glenosphere. So, yeah, what possibilities do we have to lateralize the glenoid? We have the bony enhanced offset reverse shoulder arthroplasty. This was invented by Pascal Baillot. He took from the humeral head, he takes a block and shapes it in that fashion that we have some lateralization of the glenosphere, so that we don't need to medialize with the reaming, so that we have enough contact between base plate and bone. And he has very good results, and we are also doing this in this fashion. Here we have we already had we already implanted this shoulder prosthesis. we did not have the bone anymore to make a bioarrays. So we took a lateralized glenosphere. So this has a 5 millimeter offset, and this was the other possibility to lateralize the shoulder on the glenoid side. You know, or do you have an idea what can be a problem with the lateralized glenosphere? Sorry? Tension, yeah, but what else? We have a lot of shear forces here on the bone intake, on the bone implant surface, and that due to the lateralization on the implant, and so we have a lot of shear force here on the pec, on the screws, and that can also be a problem later on. So lateralization on the glenoid has shown that it is that we have a good reduction of notching. Notching is a complication or a problem in shoulder arthroplasty. External rotation is improved. Loosening of base plates is reduced. So this was shown in some reviews. The pros for a lateralization is improved external rotation and extension, and reduced notching, and a better tensioning of the rotator cuff. So better tensioning of the rotator cuff of the remaining rotator cuff, subscap and infraspinatus give us more stability. The cons is a high load on the bone implant interface and more pressure on the acromion, so the risk of acromial fracture. The lateralization on the humeral side is also possible to make the shoulder stable or more stable. This can be done by inlay or onlay systems. We have here an onlay system. This is an inlay system. You see that you have that you are bringing the humerus more laterally through the implant design, and you also have the possibility to work with different kind of inlays with different neck shaft angles, 155 degrees to 135 degrees. So the less degree of degrees of inclination, the lesser, the more flexion you have, but at the risk, you put the shoulder at risk to luxate again. So with 145, it was shown that you have the best stability of range of motion. This is an interesting study, but it is just a computer animation study. It is not from in vitro. They had 5 different possibilities here on the glenoid side and 6 different possibilities on the humeral side, and 5 of 30 combinations showed that they have a better range of motion, more than 50%, and their recommendation showed that they have 145% of an onlay with a neck shaft angle of 145 degree, eccentric or the lateralized tray, and lateralized and eccentric glenosphere, so you can also here improve the range of motion. So it is very important that you at the beginning know what kind of system and what kind of possibilities do we have to make the shoulder stable. That's again a reduced neck shaft angle improves external rotation and notching without compromising stability. I think that's quite important to know. Here you see that we use the bioRSA. You see the gap between the base plate and the original glenoid. There is a bone block of 5 millimeters, and very important paper is presented by Wertel and Philippe Valenti, because they evaluated all reverse shoulder arthroplasties which are on the market, and calculated how much lateralization and how much medialization each shoulder prosthesis here, or each product has. It's quite interesting to know how much difference there is between different kind of products. So with each, depending on the product, you can lateralize or medialize. That's important to know. So optimizing positioning of the glenoid, how can we do that? We already said this is quite important nowadays for me to have a proper idea and to have a good imagination of how our anatomy looks like, so that we know how much retroversion, how are the angles. When I try here, for example, to medialize and to ream just to get a proper fixation, or just to be not with the dorsal retroversion in the glenoid, you will see that the bone stock will be gone. There will be no glenoid left. So it is important to judge that at the beginning and to have an idea how to do a proper positioning of the glenosphere. So what kind of possibilities do we have? We use at the beginning, we use this protocol, and we know, okay, we want to have some lateralization on the glenoid side, so we need some bone block. We can use that from the humeral side here. We can use that from the humeral side. It's here we just take a block from the humeral side, and this is our plan where we know, okay, to be in a proper, with the back in the proper, in the vault of the glenoid. No? No, no problem. That we know that we are in, ich glaube es war 80, so irgendwo. Kein Problem. Okay. Danke. Yeah, we have done this. Yeah. So we want to lateralize on the glenoid side, yeah? So we need this wedge here, and for this we use the PSI, so we patient-specific instruments, because they support that the chance of glenoid positioning is higher, and no outliers, and that's how we did it then, and we were able to put the glenoid in a correct way into this, the base plate in a correct, in a correct position with these guides here provided. The next generation will be the Nexstar. We also use that with the Nexstar. But also when you are planning, or when you have a good plan to implant this prosthesis, and to follow a plan, there can also be some troubles. Can you imagine what can be? That looks great, or no? When you look at this, X-ray here, yeah, it's a post-traumatic situation with a with this angle here in the proximal humerals. And then we said, okay, everybody knows what to do. We all know what to do. Everything will be fine. And we ended up with that. And I said, okay, I'm sure it will be correct. And then we made this AP view, but on the sagittal view, it looked like that. And then I was sure, okay, this is not correct. But we ended up like this, with that, so we took a longer stem, and but although your planning is good, you always have to check if it is correct. Yeah. So pre-operative planning for reverse total shoulderplasty, always we need a true AP radiographs, axillary view, very important, CT scans and MRI. And here I just have a case. This is a 30-year-old young woman, and she had a humeral head fracture. And with a resorption of the humeral head, we did a biopsy just to know if it is an infection or something like else. There was no infection, everything was fine. And then we had the possibility to plan. We did an X-ray from the other side, from the left side. This is the right side of the left side of the humerus, and of the left shoulder, and just to know how the glenoid looks like, because you see here there was no glenoid intact. It was completely eroded, so we didn't know what to do. But then we organized an augment. So we had the possibility to implant this augment. We got PSI, we got all things to make this operation successful. But again, on the third day or on the fifth day, we found this woman again with a subluxed shoulder arthroplasty. But here again, although I did a release up there in the subscap, in the supracromial space, because you see the humeral head, the rest of the humerus, it's stuck very close to the acromion. So we went in, and we saw that in 3 to 4 cases in those patients who had a humeral head fracture, where the rotator cuff was insufficient, and after trauma, more than one had 10 years after trauma, she had it very close, but due to the resorption of the humeral head, it got very stick very fast. But we saw that the patient or the tissue needs some time to get tension. So we just we were a little bit scared if we will be able to make it stable, but we were able to make to use a higher platform here and some little higher poly. But at the end it was just 6 millimeters. So really crazy. But this was just due to the fact that I think that the whole tissue needs his time to get long again, and when it got his length, then it's in most cases it's too less tight. So there's also an interesting paper by Pascal Boileau with a very good workflow, how to what you have to think about. You have to know on which side is the reason for the luxation. Is it on the humeral side, or is it due to the medialization? So these two possibilities you have. So these are things where you can think preoperatively, how can I manage these upcoming problems eventually. 2 slides with periprosthetic infections. We don't have that much incidence we have an incidence of 1% for all shoulder arthroplasties. The reverse total shoulder arthroplasty has a little bit more higher incidence of infection. That can be because we have a lot of space and the supracromial due to medialization and distalization. The theory is that there is more possibility for fluid, and the more possibility that there will be some germs inside. The other reason can be due that you use more the reverse shoulder arthroplasty in revision cases, and the revision per se is also a reason for infection. The most germs is the Cutibacterium acne. Risk factors are young patients, arthroplasties in traumatic reasons, history of failed arthroplasty, and the dead space, as I mentioned. What is our procedure? If it is in under 4 weeks, we can make it there. So we are just opening, making a removement of all this scar tissue and so on, and a very precise debridement, and we change the polyethylene and the mobile pieces of the prosthesis. The other would be a permanent spacer or a single or 2-stage revision. It depends on the cases. Okay, that's it. So thanks a lot. Are there any questions?